overviewing a very long and detailed report that we did for the GLA, Greater London Authority, on the impacts of structural racism, discrimination, and ethnic inequalities in the health and social determinants of health in London. And we made a lot of recommendations. So please do go back to the original report, because there's a lot more detail than I can present here, but I will give an overview. But just to say, as an institute, as effectively the Mama Institute, we have had a long-standing focus, of course, on social economic inequalities in health. So this was, I think in 2010, we added the 8th principle to our existing 6th principle. We added 2 more, one on sustainability and environmental concerns, and one on racism and discrimination. But this was really our first in-depth look at the impacts of structural racism and discrimination on health. A reminder about the state of health in England, which is pretty dire, as you're all very aware, I'm sure, and the levelling off in increases in life expectancy, which we'd come to expect 1 year every 4 years. Previously, you could trace this trend line right back to post-war, probably even pre-war if the data was up to it. Nice increases in life expectancy that began to level off. We've associated that stalling in life expectancy, females, males, to the impacts of austerity and then the drop for COVID. And we can see clearly, I said we focused on socioeconomic conditions, neighbourhood deprivation. So every dot is a neighbourhood in England. The least deprived neighbourhoods up here, the most deprived down on the left-hand side, and life expectancy. So you can see this very close association between the level of neighbourhood deprivation and life expectancy in England. All of us live somewhere on this distribution. If we live in England, and there are similar distributions actually everywhere we look, and within Coventry, of course, as well. Inequality in health has increased. This is inequality in female life expectancy. It's similar for male. The darker regions, the more unequal, and you can see that between 2010 to 12, 2017 to 19, everywhere, apart from London, has become more unequal, every region. And that's true for most places, most local authorities as well. Healthy life expectancy, pretty dire. So that's how long you can expect to live in good health. Females, it's been declining. Males, it was increasing slightly and then subsequently declining. And unfortunately, this decline has continued and accelerated for both males and females past this point. And again, healthy life expectancy, very associated with deprivation. Most deprived 10% of England's population, with healthy life expectancy around age 51, 52, females, males, right up to 71, and 70 over here in the least deprived neighbourhoods. So socioeconomic conditions are clearly an extremely important driver of health. And what we want to do is raise and flatten that gradient. This is a graph which continues really to appall us. It's the change in government funding per head of population. So there have been decreases in funding. This is since 2010, of up to 50% in some local authorities. But if you look at what life expectancy was like in 2010, and then the subsequent decreases in funding, you can see that the areas with the lowest life expectancy, the most deprived areas, experienced much greater cuts, completely the opposite of what we would have wanted to see, where we would have expected this to be proportionate to the scale of deprivation in health, i.e. that local authorities who are wealthier had and less poor health and less need had greater cuts, but the reverse happened, which accelerated poor quality environments, conditions, and poor health. So no wonder we've seen declines in health and widening inequalities when you begin to look at some of this. So those are the big socioeconomic drivers. And of course, within that, there are groups who have experienced particularly significant impacts from deprivation, from poverty, and then additionally, the experiences of discrimination and structural racism. And that was what we were really trying to get into with this review. So it was funded by the GLA, and they wanted us to help them understand the impacts of structural racism on health. So that's in relation to access to services, the quality of those services, rates of poverty, and all those key social determinants of health, those building blocks of health, and how racism and discrimination impacts on people's ability to lead a healthy life. They wanted us to develop recommendations for action and to inform public health and other stakeholders. So our recommendations are very broad ranging. And they're for community groups, they're for local authorities, they're for the GLA, they're for national organisations and policies and policy-making groups, and as broad as we could be given the breadth of what we were looking at, all those key social determinants of health. And of course, the views, there's insufficient data. That's another important point to make. We managed to find quite a bit of data, but everywhere across England, there is insufficient data to really understand the experiences of ethnic communities in England and how those compare with other ethnic communities and those trend lines in particular. So we know there's data gaps here, much more than there are for socioeconomic inequalities. And the voices of communities and those with lived experience are absolutely vital. We ran a consultation with community groups. They were involved in the advisory board very much. And the Race Equality Foundation works very closely with the community sector, and they had a big remit in the formulation and consultation with our report. So the report really is a mix of data that we have, reports that we could find, these accounts of racism and the impacts that it had from people with lived experience and community groups and representatives, such as faith organisations and so on. And we tried to do what we could. There were lots of constraints in terms of time and resources, of course, but we tried to make sure that we didn't just rely on the rather patchy data. And our conclusions or our introduction to the report is very clear that racism in the capital is widespread and persistent, and this causes damage to individuals, to whole communities, and to society as a whole. But of course, its impacts are experienced in different ways, and that relates to individuals' experiences, of course, how much racism and discrimination they personally experience, their socioeconomic positions, so people in more deprived situations from ethnic minority groups are more likely to A, experience racism and discrimination, and B, not have the resources to withstand its impacts. So in relation, you can imagine, to access to services and jobs, the impacts are far greater for those with lower socioeconomic position. And then there's other factors to be considered: disability, age, and gender. So we heard from groups who, from ethnic minority groups who had disabilities, older, female, other dimensions of discrimination and exclusion where the effects were cumulative. So these intersections with other dimensions of exclusion can amplify the impacts. All the data that I'm going to show you from now on, apart from this slide, is from London. I imagine that the similar data is available in Coventry, but I will say that the summary that we did in London, for London, hasn't been replicated elsewhere to the same extent, at least not by public health, which is our position. And we think we've been working with other local authorities and other places to try to develop similar analysis for London. Of course, London has its unique context, demographics, but and data, more data available in some places potentially. But we think that there's much more that local areas, public health can do to really focus on ethnicity, inequalities by ethnicity, and these impacts of racism and discrimination. And in Coventry, as you will know, you have a growing ethnic population and a declining white population, and you have a diverse and mixed population, more so than many towns and cities across England. In London, they have the Survey of London, which is repeated relatively frequently, which is a fairly comprehensive survey. And we got a lot of data from that survey that isn't necessarily available everywhere. They surveyed the percent of Londoners who report being treated unfairly by a variety of characteristics: sex, gender, age, social class, religion, disability. But ethnicity is the one which flags up as the characteristic most likely to lead to unfair treatment. And experiences, you can see also that between 2018-19, 2021, that proportion has risen quite a lot. So that's a concerning look into the scale, both the scale of discrimination and the fact that it could well be increasing. And if you look a bit more detail at who it is who's reported being treated unfairly because of protected characteristics, you can see that for Black groups, that proportion has grown quite a lot. Also for Asian groups, that's the average for London. So you can see that now Black groups are experiencing considerably more unfair treatment from this survey than other groups. White British down here is actually declining those who report they feel they're being treated unfairly. So that's the context in which we were working. And we've summarised really that there are three main ways in which racism affects health. It can directly damage mental and physical health, of course. So the physical impacts of experiencing discrimination and racism, and of course, particularly those mental health impacts, which then impact physical health. So that's the most direct and immediate way, but also it drives socioeconomic disadvantage, access to employment, low levels of pay, and so on, which then leads to poor health. And then racism experienced in services, which harms health. So we've kind of summarised the report under these three ways that racism can impact on health. Often, especially in the NHS, of course, there's a focus on racism in access and experience of services, but we very much focused also on this socioeconomic disadvantage, experiences in the early years, in education, in employment, in feeling safe, access to outdoor spaces, and so on. Another important point to make is that the life expectancy data by ethnicity is really complicated, and we didn't focus on this. There are many factors which current estimates don't take account of, for example, people's migration history, different age structures, and these socioeconomic differences. So because it's complicated and far too weak to really draw any conclusions from, we just put the life expectancy data in an annex, and we hope that better data, the ONS, will provide better data on life expectancy. But we did look at the age standard, the percent reporting they have a limiting illness or disability, which gives us an insight, I think. And you can see here, Gypsy, Irish travellers, very high rates of limiting illness or disability, and Bangladeshi, Arab, Pakistani groups as well, much higher levels than the average here, the all ethnic groups here, and those with the lowest here. So we know that some groups are experiencing particularly limiting illness, and you can see here, this is a complicated graph. You will have access to these graphs, but the more time that you spend in the UK, the worse your health gets, which is perhaps a concerning finding. It might relate to people aging, of course, as they stay in the UK. We need to look further at this. But if you see, this is limiting illness. So the higher rates is worse health. And you can see, for example, Bangladeshis here, people who have been here less than 2 years, about 40% have a limiting illness, but this increases. And for many groups, you'll see these increases the longer people are in the UK and born in the UK. So again, something there to be really unpicked about why it is that we see these increases in poor health over time as people arrive in the UK. Turning to healthcare services, there are many ethnic inequalities in health and accounts of racism. maternal health and mortality, you'll all be aware of really stark and shocking inequalities in maternal health, in infant health, also, and set out in the report different rates of mortality from specific conditions, much higher in some ethnic groups than others. Similarly, mental health, particularly for Black groups who experience worse mental health and much worse experience and access to services. And then we also see inequalities related to life satisfaction and well-being by ethnicity, and in some of these health behaviours, smoking rates, alcohol. Complicated picture, and it's not all, that white groups have better outcomes than others. So we need to really dig down into specific ethnic groups, specific health conditions. And the point of saying this is that the health services need to be much better attuned to the needs and different health profiles of different ethnic communities. So, for example, diabetes, specific South Asian communities, some Black communities have much higher rate incidence of diabetes. White people have higher smoking rates, although it's also high for males among Indian groups and so on. So we need to really look in much more detail, in granular detail, to make sure that service provision is adequate for the needs in all these groups. I mentioned the percent of people with high or very high life satisfaction by ethnic group. You can see white British, white other, Black and mixed communities, much lower rates of life satisfaction. I've talked about the different needs related to different health conditions and therefore different services needing to respond differently, but there is evidence, a lot of evidence of particular issues in some services, mental health and maternity services. Repeatedly, these issues have been flagged that services, there's not good access, there's services that are not well set up necessarily to deal with different needs, and that there's outright discrimination and racism in mental health and maternity services. We also looked at medical practice. A lot of medical practice and teaching materials and teaching is based on white bodies, and the Race and Health Observatory, the NHS Race and Health Observatory, have been focusing on this and show that some treatments, some practices, newborn health, for example, people are taught, medical practitioners are taught around skin colour and what that means for newborn health, but that doesn't take into account non-white skin. So medical practice is an issue. Medical technologies, often based on research that's majority white people, white physiology. For example, some cancer treatments, the physiology means that they're processed differently, and that hasn't been taken appropriately into account. And then, as I've said, research needs to take into account much better diversity of different physiologies and ethnicities. And then there's many accounts of racism experienced by employees within NHS and social care, from managers, from other colleagues, and from the public, of course. And this has not been adequately dealt with, and still is in existence despite many reports over many years. Here are the maternal mortality rates. This is across England. You can see that for Black mothers, the maternal mortality rate 3 to 4 times higher than Chinese and white groups. And these have been reported on for a number of years, but they persist. The infant mortality rate, this is also England and white. You can see lowest in white groups here, and much higher Black groups, all the way Black Caribbean, Black African, Pakistani, Bangladeshi. So infant mortality rates vary enormously by ethnicity. And again, this needs to be addressed. What is happening that's leading to these much higher infant and maternal mortality rates? Common mental disorder, I've mentioned, higher among Black and mixed other groups, much lower white and white British, quite high actually across the board, but you can see these differences for women. They're not so apparent for men, according to this, but this could be about diagnosis and reporting as well. And the detention rates under the Mental Health Act, you can see much higher detention rates for Black groups. And we're beginning to get a picture of this kind of accumulation of worse health among specific ethnic groups. And of course, we do be presenting it, by maternity, infant, into mental health and so on. But of course, these are people who experience all these different factors across life. So in terms of health outcomes and in terms of all these key social determinants of health that we'll talk about in a moment, we need to think of the cumulative impacts right from the earliest years through to older people, and how these experiences of discrimination and worse outcomes and racism impact accumulatively across life. We have recommendations. I won't talk too much to these. They're there in the report, to end racism in health and social care, in those areas that I've highlighted. And then we also cover the key social determinants of health. So these are our 8 Marmot principles. So we took every one of these for London and looked at what we could related to differences by ethnicity and experiences of racism and discrimination, in these 6 areas. We did obviously tackle racism and discrimination and outcomes, ran through all of that. And we haven't looked at pursue environmental sustainability, but we know that there's quite a lot of data showing that particular ethnic communities will be impacted more, even within England and certainly globally, by climate change. Percent of children living in low-income households after housing costs, some really enormous differences here. And here, Pakistani and Bangladeshi communities with nearly 70% children living in low-income households. It's astonishingly high. We're looking at the average for England of around 30%, the average for London at 40%, but these enormously high, wide differences between ethnic groups, and astonishingly high rates here for Black, Pakistani and Bangladeshi groups. Much lower rates, Chinese, white and Indian, and we see these much lower rates in poverty and access to employment, etc., for these 3 groups in particular, in many of the factors that we looked at across London. We then looked at experiences for children, young people and adults, so through education, criminal justice system. I'm not covering that here, but obviously that's an enormously significant impact on particular ethnic communities in London, and feelings of safety and so on as well. Very, very stark, particularly for young people, frightened to leave home, be in public spaces, be on public transport and so on. But here looking at the education, and percent of people meeting the expected standard of reading, writing and maths at the end of Key Stage 2 by ethnic group. We take it right back in the report to early years development, preschool development, through school. Here we're looking at the end of Key Stage 2, and you can see very high rates for Chinese, Bangladeshi, Indian, Black African groups. For free school meal children, the darker bands, as well as children not known to be free school eligible. So we can see the inequality between non-free school meal and free school meal children, but also these enormous differences by ethnicity. The white British here, as I said, this isn't a particularly clear picture. It's not that white British groups always do better, but bear in mind, and we'll come on to it, white British groups here not doing particularly well at Key Stage 2, Bangladeshi, Indian, Black African doing very well. So really positive and encouraging that some of these ethnic inequalities in education have reduced significantly over the years, and schools are doing reasonably well. There are accounts of racism and discrimination within schools and inappropriate services, Black boys in particular, having poor outcomes in many areas, and schools not well set up to meet their needs. But on the whole, we can see here that many ethnic minority children doing very well at school. Chinese, Indian, Bangladeshi, Pakistani, you can see here our highest average attainment 8, that's at age 16 scores by ethnic group. And in London, many kids do better in school than other parts of England, particularly those in poverty. However, when we come on to employment, you can see enormous differences. Lowest rates of employment for Bangladeshi, Pakistani, Arab, Black African groups. Those kids that were doing very well at school and getting high levels of attainment now drop away. What is going on as people begin to access employment and are able to have higher incomes? And you can see here differences by pay as well. Chinese, Indian, white, Irish, white, British, white, other, much higher rates of pay. Bangladeshi, Pakistani, Black Caribbean, much lower rates of pay on average in London. So again, that transition from education into employment. So what are employers doing? There's very little scrutiny or accountability on employment and on pay. Ethnicity, pay by ethnicity isn't reported on. The Labour government have said that they will address this and have a mandatory reporting on pay by ethnicity. But where we can get the data, you can see there's really stark differences. And as I pointed out, this doesn't relate to how well kids are doing at school or their educational attainment or skills. This is something else discriminatory happening here. And again, you can see these enormous differences among groups who'd never worked by ethnicity: Irish, white, white British, up the top, lowest rates here. So again, much higher Bangladeshi, Arab, Pakistani, other ethnic groups, Gypsy and Irish travellers. Moving into, this is where we talk about poverty and income. Again, very wide differences in poverty rates. I showed you the rates for children, 60–70% among Pakistani and Bangladeshi children. And then you can see how this manifests. This is differences in ethnicity by people who can't keep their house warm enough to be healthy. White British, the lowest rates, much higher. Black, mixed groups, that's increasing. We'd expect to see that increasing even further, of course, as fuel costs have increased and poverty's deepened. Food insecurity, white British on the left-hand side, Black here. Again, these big ethnic differences, Black communities experiencing far greater food insecurity, poor quality housing, and much deeper higher rates of poverty, as we've said. And then those people who need it most have less access to support organisations, or at least they're not aware of them. So here there's very clearly a need to try and improve access to, in this case, financial support hardship support organisations. These groups here are less aware of support. So that's a thing for local places, I guess quite an easy win relatively, to try and address access to services that are in place, access to support. There are inequalities in who can access it, who's aware of it. Moving into housing and environment, as I said, there's much more in the report. This is just a flavour of the kind of data that we're showing. And when you see the volume of data that we've got and all the accounts and experiences that we've managed to incorporate into the report, it's these cumulative experiences in all these different facets of life that you can really understand the scale of the impacts, perhaps. This is Londoners, percent of Londoners in what they're rating as very good or good ethnic good housing, rented housing. White British higher, Black much lower, believing that their rented accommodation was good quality. Living in overcrowded accommodation, mixed Asian, Black, and this other category. And again, as I said, the data's not great in many of the sources that we have available, and it's a bit broad brush really. We tried to use a more fine breakdown by ethnicity, but even that, you know, there's a huge variation between Black communities and Asian communities in London, Black African, Caribbean, and this doesn't take account socioeconomic position. So of course there's people doing very well in all these groups, but we're having to talk about these rather crude averages because of the data. We also incorporated many case studies. My colleague Scarlett Willis may be on the call as well. I'm not sure if she's here or not, but she worked with, I think, over 80, was it, Scarlett, if you're here? She worked with over 80 organisations and sectors, community and voluntary organisations, and we've got all the case studies in the report where they're really supporting and trying to address many of the challenges experienced. And these range from local authorities, parts of the healthcare system, a community and voluntary sector organisation doing fantastic work often on an absolute shoestring to try and address these inequalities and support communities to better health and better outcomes in the social determinants of health. And there's all kinds of issues around this, even where there's evidence of great impacts, and they're doing fantastic jobs. The funding is so difficult to access. It's tiny pots of funding. They're very short in terms of timescale. So these tiny community groups having to spend an awful lot of time trying to access funding. And they come and go as a result. So clearly issues there around the way that support is set up. But we have got these fantastic examples from across London. There's an awful lot happening that's positive, just not on sufficient scale. And it's not built into the kind of systems in a way that we need it to be. So therefore, the implications for what we've shown are that all services need to be attuned to ethnicity and age, as well as levels of deprivation. So there is increasingly an understanding about the impacts of deprivation, but as I've said, services, and I'm thinking particularly about health services here, are not necessarily well attuned to the differences by ethnicity and age. Services need to be culturally aware and appropriate, and strong advocates for this. So having anti-racism organisations, it's all very well having EDI policies, although they are under threat, and I've seen today what's happening in the States, which are trying to ensure equal opportunities, but we need to go beyond that and to be advocates, to understand about the different outcomes by ethnicity, the extent of racism, and how that impacts health and the social determinants of health. And there are a few very strong advocates, but we need them from across every organisation in every sector. So that leads into this strengthened leadership for anti-racism. And Kevin Fenton, who's the Regional Director of Public Health in London, has been really advocating hard on anti-racism approaches, which are much stronger than EDI. And you need stronger legislation. The existing mechanisms are too weak and not well applied. So the equalities legislation, the regulation and accountability are all far too weak and really need strengthening. It's very difficult to report experience of racism for individuals, and then it's often overlooked, ignored within organisations. And the onus becomes on the individual rather than on the organisation to take it forward and deal with it properly, and it's not well supported. To take an equalities case, for example, legally is really difficult, and there's very, very high criteria. There's not many organisations and legal systems to support that. So really need proper legislation, regulation that's built into the regulatory bodies to Ofsted, CQC and so on, and we need much stronger accountability. There's lots of, I won't dwell on these, but we've got lots of recommendations for how organisations can strengthen their anti-racism approaches. And I will emphasise again that this needs to be within the private sector as well. And this isn't just a job for the public sector to do. We need those employers, we need the private sector, and often racism within the private sector is more highly prevalent, unacknowledged. You can't report on it, and there's no accountability. So again, employment and private sector organisations, I think, need to take a stronger stance on this. I'll stop talking because I've presented quite a lot of material, but hopefully we have good amount of time now for a discussion, and very much hope that this, I know you're doing a lot in Coventry already around these issues, but whether there's more that could be done, and I hope that this report is helpful in those endeavours. Thank you.